Hello, my name is Dr. Deborah Cohen, and I am the MAVEN volunteer moderator for today's session on adult ADHD with Dr. Charles Norris. And our host anchor clinic is Tri-Cities Community Health. Let me tell you a little bit about Dr. Norris. He is currently clinical affiliate assistant professor at the Schmidt College of Medicine at Florida Atlantic University, teaching medical students in the neuroscience department. For over 25 years, he had a private practice in general psychiatry until retiring. He has been the director of the outpatient department at the Institute of Living, a 400-bed psychiatric hospital in Connecticut, served as the East Coast psychiatric medical director for MetLife, and has run an alcohol and addiction unit in Florida. And with that, Dr. Norris, you're free to start.
Thank you. Good morning, everyone. So today we're going to talk about ADHD. Sometimes you'll see ADD, so that's attention deficit hyperactivity disorder. ADD is simply without the hyperactivity, attention deficit disorder. This is one of the things that can be very rewarding to treat. It can also be very frustrating, and we'll talk about that as we go through the talk. Disclosures, I have no disclosures. So our objectives are going to be in 4 areas. We're going to talk about how to diagnose it. We're going to talk about how to deal with comorbid differential diagnoses, how to identify red flags, and that's an important area in treating this, and then how to implement a treatment plan. A recent report I saw said there's 15.5 million US adults with ADHD in this country. Only 1/3 of them get treated, and 3/4 of the ones that get treated have difficulty in filling their prescriptions because there's always shortages of Adderall and Ritalin. Now, I'm going to start out talking about a patient I had early on in my private practice. Sam was a biologist, and he worked in the Keys, and he loved his work. He worked outdoors, he worked with animals, he worked with fish, he worked with the ocean, he worked with the wildlands in the Florida Keys, and just loved it. And then he went and got a promotion. When he got a promotion, he started to struggle. And this eventually got him depressed, and eventually got him to come and see me, even though his drive was almost 100 miles from the Florida Keys up to Boca Raton, where I live. And why did he struggle? Well, his boss started complaining his reports were always late. He was working from morning till night. This upset his wife. She complained he was never home. She'd ask him to do things, he would forget to do them. He started to fear he was going to be laid off. He got laid off. He feared his wife would leave him, and he'd have to move to find work. During the evaluation for his depression, but we discovered that he was easily distracted. He admitted he was a procrastinator on starting paperwork because it was hard to focus and concentrate, and he would always get distracted. He'd forget to do things altogether. This led to arguments with his wife because she asked him to do things that he'd forget to do them. Many of these symptoms went back to childhood, but he had always managed to deal with them. He was an average student in school, but he always did much better in classes like biology because he really enjoyed them. And those are some kind of key marks of adult ADHD. So how do you diagnose ADHD? Well, the easy way is just to go to the internet, because in the internet, there's tons of information on this, and people can really self-diagnose. So this came right off the internet, asking, do you have ADHD? They talked about, do people say you're forgetful? Do people complain you don't listen? Are you often late? You have trouble concentrating? You leave things undone? Did you have behavior issues as a child? Did you lack impulse control? Are you unorganized? Are you fidgety? Do you have difficulty controlling your emotions? So these are some of the key issues that you'll see in ADHD. In children, children get referred because of school. And they go to school and they have impulse control issues, and they're talking to their neighbor, and they're always getting in trouble, and they're fidgety. They're not doing well on their schoolwork, so the teacher sends them to the principal. The principal calls in the family, and the family sends them off to be diagnosed for ADHD. When you get to adolescence, sometimes kids do okay in elementary school because there's a lot of structure, but as they start to get into where they need to do more of their own structure, like when they go off from high school to college, so sometimes adolescents come because they want to do well now and they recognize that they're not keeping up with their peers, so they'll come for treatment. Adults often normalize their behavior, so they don't really notice it until someone else starts complaining to them about it. Interestingly, some of my adults would come because I had treated their kids for ADHD and they saw how well their kids were doing with treatment, and they would come and say, you know, I have all these same symptoms myself for my whole life. And then when you get into their history, you'd start to see some of those difficulties that came from their difficulties with impulse control, focus, concentration. One study I always thought was very interesting. They took a group of students with ADHD, compared the medicated group to the non-medicated group, but they all had the diagnosis of ADHD. And what they did is they examined speeding tickets and running red light tickets. So which group do you think had more tickets? Well, obviously, it was the group that wasn't taking the medication. And to me, this always underlined the fact that ADHD affects more than just school performance. And that certainly applies to adults. Now, one of the problems we're going to see is that the current diagnoses in the Diagnostic and Statistical Manual is really designed for children and adolescents, not adults. And there are currently several groups trying to work on adult-related symptoms, but you have to kind of look at the symptoms and then translate them from children and adolescents to how it would be in adults. Also, they're really focused on boys. And this is one of the reasons that girls and women are often underdiagnosed. So little Billy can be in the back of the class throwing spitballs, talking to his neighbor, getting in trouble. He gets sent to the principal and it's recognized that he's got a problem. Little Susie can be sitting in the back row, spacing out. She's not really hyperactive or causing problems, and they just let her float through with average grades and don't pick up on the fact that maybe she could do much better. So many times women don't find out they have ADHD until college or later. People with a higher IQ can mask their symptoms. Hyperactivity can be internal or look normal. One of my patients who was a practicing psychologist and doing pretty well told me that taking Adderall for the first time was like putting on reading glasses, and he hadn't even realized he needed them. And I always liked that metaphor, that it was like helping people to clarify when they had difficulty doing it otherwise. And again, if they're very intelligent, they could often cope, but probably not living up to their best life. So ADHD can damage relationships. It can damage one's self-esteem. It can damage finances. They spend impulsively. They don't save. It can cause legal challenges, speeding tickets, running red light tickets. They work below their ability, so they have constant work problems. And some studies suggest it robs them of 10 to 15 IQ points. So those are all good reasons to help people. And when they get treated, it really makes a difference, and you can really feel like you've done something useful for people. Now, when I first trained, we were taught adults outgrow their ADHD symptoms, but now we know about 60% continue with symptoms. I mentioned before, there are a couple of groups that are trying to develop adult guidelines. So critics complain that it's overdiagnosed because we see a lot more people being diagnosed with ADHD. Probably we just didn't recognize it in the past. Probably because it's more written about and known, more people look for it. But professionals find it still underdiagnosed and recommend universal screening. So 80% of adults with ADHD have comorbidities. So when we talk about the differential diagnosis in a minute, you'll see that many people, these symptoms can overlap with other kinds of psychiatric diagnosis. One of the challenges is there is no definitive objective test for ADHD. So unfortunately, you can't do a lab You can't do an MRI or a CAT scan, say, aha, you got this, and we know to treat it. So the diagnosis is based on history. And again, remember, adults tend to normalize their symptoms. And many times until someone else points out to them, they don't even recognize it as a problem. But they may be spacey, they forget to pay bills on time, they're prone to road rage and frustrated, they may blow up when distressed, and this can affect many aspects of their life. One mnemonic I heard recently was PDF, procrastination, distractibility, forgetfulness. For those of you who like mnemonics, maybe that'll help you remember what to look for. Now, the DSM-5 is the Diagnostic and Statistical Manual that American Psychiatric Association puts out for all psychiatric diagnosis. So they have the official criteria for ADHD, and they start out by saying it's a persistent pattern of inattention and hyperactivity or impulsivity that interferes with functioning or development. Then they give you a whole list of symptoms. And I'm not going to go over these because I'm going to give you an easier way of doing it. But if you want the official way of doing it, DSM-5 tells you all that, tells you how to break it out, how to make the diagnoses. For practical purposes in a clinic, there's screening tests. So we're gonna look at it more through the screening test. So the one that's used most often and happens to be free and online and available, so you can call it up online, print it off, and the patient can fill it out. So you don't even have to take the time to fill it out with them, but you can look at it and then ask them questions about what you see and what they filled out. So this is the Adult ADHD Self-Report Scale, or the ASRS version 1. That's what it looks like in whole. I know that's small. I don't expect you to read that printing. So I broke it down, and we're going to look at it closer. So 6 of the 18 questions were found to be the most predictive, and that's what these 6. Hopefully you can read that. You can see that there's dark area, and if there's at least 4 checks in that dark area, you know you've got a positive screen, and you should probably look harder. So again, these are things that we've already looked at with different wording. How often do you have trouble wrapping up the final details of a project once the challenging parts have been done? That's the procrastination. That's what happened to my biologist who couldn't do his reports and was struggling with his promotion. How often do you have difficulty getting things in order when you have to do a task that requires organization? He would get distracted. He would start doing one thing, get distracted, start doing something else, get distracted, start doing something else, and the first thing never got done. How often do you have problems remembering appointments or obligations? Are they late to things? Do they forget birthdays? Do they forget the things that they're supposed to be doing? When you have a task that requires a lot of thought, how often do you avoid or delay getting started? So again, the procrastination part, the forgetfulness. How often do you fidget or squirm with your hands or feet when you have to sit down for a long time? Are you one of those people who sits in the meeting and you're always tapping your toes and squirming in your seat, have to get up and move around a little bit? How often do you feel overly active or compelled to do things like you were driven by a motor? That's more of what you would see in kids, but occasionally adults can relate to that as well. So again, as I said, 4 more marks appear, then it's a positive screen. The second part of the screen is giving you a lot of other symptoms that go with ADHD. They're not considered to be definitive, but they're considered to help you define how serious the issue is and does it need to be treated. So the more pluses you see, in the gray side, the more you want to focus in on those, because it's going to help you know, is this really affecting their ability to function in their life? And again, very quickly, how often do you miss careless mistakes when you have to work on a boring or difficult project? How often do you have difficulty keeping your attention when you're doing boring or repetitive work? And again, many people, when they're doing something that's of high interest, the biologist, when he was doing biology in the field, he loved it. But doing paperwork is not something he liked to do. How often do you have difficulty concentrating on what people say to you, even when they are speaking to you directly? People would often tell him, you know, I just told you this 5 minutes ago. Why are you asking me about it again? Because they're not concentrating. How often do you misplace or have difficulty finding things at home or work? How often are you distracted by activity or noise around you? Some college kids need spatial ability to have a quiet room to do their test. And they can get that if they have a diagnosis of ADHD, they can get the school to let them take a test in a room where there's not a lot of noise because it affects their test taking abilities. How often do you leave your seat in meetings or other situations which are expected to remain seated? How often do you feel restless or fidgety? How often do you have difficulty unwinding and relaxing when you have time to yourself? How often do you find talking too much when you're in social situations? When you're in a conversation, how do you find yourself finishing the sentences for people you're talking to before they can finish them themselves? Again, that's the distraction part. You're not paying attention to what they're saying. You're thinking about what you want to say next. How often do you have difficulty waiting your turn in situations when your turn taking is required? How often do you interrupt others when they're busy? So these are things everybody can relate to. Sometimes people with ADHD, it's affecting them much more and interfering with, again, their relationships, their jobs, sometimes with the law. Again, part of it is impairment. So not only do they have the symptoms, but is it impairing their social, familial, occupational functioning? And again, as we said before, the symptom frequency is often associated with symptom severity. So that second part of the screening test can help you know more about symptom severity. The second part, once you've got the symptoms down, is longitudinal history. And they always recommend that you get further information from some other source, whether it's a mother or a spouse or a friend or a coworker, or in the case of adolescents and children, teachers, who see some of these symptoms as well, because many times the individual themselves do not see the symptoms and other people see them. So I also do screening tests, and I'll send them home and have your mother fill this out, have your wife fill this out and bring it back with you. Adults who have had ADHD need not have been formally diagnosed in childhood. Earlier on, that was one of the criteria, that if you didn't have it in childhood, then you don't have it as an adult because adults outgrow it. Well, now we know that's not quite true, and we know a lot of children never get diagnosed. So they think they didn't have it as a child, but they really did when you look more carefully. So the longitudinal history, the collateral history from these other folks. And again, you can there's a whole bunch of forms out there to diagnose ADHD, so you can send those home. This happens to be one that, again, it's free and available online. It's from a guy named Wenders. It's taking all these same symptoms we've talked about and slightly rewording them in other forms, and oftentimes trying to get them more adult related. If all that seems too much, and again, in a clinic setting, you don't have a lot of time with an individual patient, at least in private practice, I would often send them off to a neuropsychologist for neuropsychological testing. And they would often put out a 10, 15-page report in detailing the problems with focus, concentration, paying attention, easy distractibility. And this often was necessary for special accommodations in school and college. Again, I don't know if your clinic, if that's actually something that's available to you, but if it was, that's a nice way of getting the information. This is simply another common screening test that I used in my private practice. It was self-reporting, and it was more related to adults and gave you further information in terms of that collateral history and longitudinal history. This is just another one. I put some of these in here so that you'd have them as references if you want to go back to them. I don't think we need to spend a lot of time talking about them. So the second part, once you feel like you've got someone with ADHD, you want to know, is it really ADHD or is it something else? And this is the differential diagnosis. What you'll find, though, interestingly, is what we're finding is many times there's comorbidity. So my biologist came to me for depression, which he had, but he had it because his ADHD was screwing up his life. So we ended up having to treat both. So people with depression also have difficulty with focus and concentration, but in addition, they have difficulties with sleep, appetite, anhedonia, nothing's any fun anymore. Anxiety disorders will often interfere with people's functioning. They may have more energy because of their anxiety. But if their life's not going well, that stress may trigger anxiety. So ADHD can trigger stress. Stress can trigger depression and anxiety. Bipolar disorder, this is a type of depression where not only do you go down, but you go up and down. If you go way up, that's manic depression, which we now call bipolar 1. They have flight of ideas. They have lots of energies. They're up all night. They can't stop talking. So there's some similarities there with ADHD, but ADHD is not to that degree. ADHD people have fidgety energy. Bipolar patients have unlimited energy. There's bipolar 1, there's bipolar 2, which is more depression with mood swings. There's cyclothymia, that's mood swings. So bipolar disorder also has a lot of crossover symptoms with ADHD. Borderline personality disorder, this is someone who has more of a learned behaviors. It's a personality or character disorder. It's fairly common, but it can often get confused with ADHD. And then, of course, substance abuse disorders. People who use cocaine are going to have more energy. They're going to talk faster. They're going to do things that are impulsive. Here's where it gets really confusing, because the medicines we use in ADHD are Schedule II drugs that work the best, and they're often abused by substance abusers. Interestingly, one of the things I used to ask my cocaine abusers is, does cocaine speed you up or does it calm you down? Because in ADHD, there's a paradoxical reaction in terms of energy, and people get a calming effect with stimulants. But in terms of comorbidities, studies show that up to 80% of adults with ADHD have comorbidities. So chances are, if you're treating one, there's something else there as well. 75% of children with ADHD have comorbidities. 20% of bipolar patients have ADHD in one European study. So that's a 20% overlap. Studies show damaged neural activity in untreated ADHD. So they're even starting to see physical signs of damage due to ADHD. So one of the quotes that I took out of it, another talk that I listened to, was untreated ADHD becomes complicated comorbid ADHD in adults. So it's something you want to treat. It's something that's fun to treat. It's something that's relatively easy to treat. Again, I'm not going to go over these, but in terms of those comorbidities or differential diagnosis, there's screening tests for depression, and you probably already used the PHQ-9 mood disorder questionnaire for bipolar. This is the McLean screening instrument for borderline personality disorder. This is part of the PHQ test. This is the generalized anxiety disorder, the GAD-7. So again, just the concept that there's a lot of overlap of symptoms here, but there's nothing to say you can't have two instead of one. Again, if comorbidities are present, I recommend you refer them to psychiatry, but I recognize in the clinic setting that's not always available. One question comes, which do you treat first, ADH or comorbid condition? In the past, for example, the patient with depression, we used to say treat the depression first. And that's how I would tend to do it, and then treat the ADH later. Although recent studies show patients' depression responds better when you treat both. Dangers: bipolar patients with ADHD have a higher rate of impulsive suicide attempts. When the ADHD is treated along with bipolar, fewer suicide attempts were reported, with fewer psychiatric hospitalizations and self-injury behavior. Also, substance abuse patients, you're going to be reluctant to treat a substance abuse patient, but if they have ADHD, they're going to be more prone to impulsive relapses. So this brings the third part of the talk, and that's talking about red flags. So we've identified a patient from the symptoms. We've looked at the differential diagnosis and possible comorbid conditions. So what are the red flags? Well, again, the big one is the most effective medication is stimulants, which are scheduled drugs and may be abused. Adderall, which works best in adults, Ritalin, which probably works best in kids, are both Schedule II drugs. and they will be misused and abused. It's a challenge in college-age kids because they come in and you have to be careful of overdiagnosis because the college kids know all the symptoms. I mean, I just showed you, you can look them up online. So they can come in and give all the right answers on the screening test and look extremely ADHD, when in reality, they're either looking for the smart pill for themselves, they're looking for an edge. Of course, college kids also will sell them to their friends and make money. So you have to be aware of diversion and can make it very difficult and challenging. And yet at the same time, you don't want to underdiagnose it because, again, many times it'll help them do better in school and be successful in life. In particular, watch out when the college kids are seeking short-acting stimulants because those are the ones that are more abusable than the longer-acting ones. We're going to talk about some of those in the final part of our talk to try to get around that. So you've got this balance. You want to treat people who need the treatment, and yet you don't want to contribute to someone who's misusing or abusing drugs like Adderall and Ritalin. So one of the things to remember is not just the symptoms, it's look for impairment more of the one area. Here's another area where you get some collateral information from a teacher or something, you're going to feel a little bit stronger about treating it. Unfortunately, college kids will often get their friends to corroborate their symptoms, but can you trust their friends any more than you can trust them? It's unclear. If you can get a parent involved, that's helpful. I know in Florida, and I suspect most states now have some kind of state prescription drug monitoring program. So this is one way to make sure that you're not dealing with a patient who's double dipping and going to other physicians to get their drugs. And it didn't happen often, but it happened enough that made you a believer in looking at the drug list before you wrote your prescriptions, that they weren't getting their drug from their internist and their family practitioner and you all for the same drug in the same month. So that's a useful way to try to help cut down on diversion. Medical treatment. So we're going to talk a little bit about medical treatment. And basically, one of the questions you have to ask yourself is stimulants versus non-stimulants. The easy answer is stimulants works better, but non-stimulants don't get abused. So again, you've got this pro and con. Sometimes you'll have parents of students who don't want their kids on stimulants, and that's fine. So they are available, but generally aren't as effective. So in the typical patient, you'd start out asking yourself amphetamine or methylphenidate, and there's a lot of different stimulant type medications, but they basically break down to amphetamines, Adderall-like drugs, or methylphenidate or Ritalin-like drugs. Now, historically, Ritalin was the first one out. And when they started using it back in the 70s, they saw that it was effective, but it lasted about 4 to 6 hours. So kids would take it before they went to school. They'd go to school, they'd do well in the morning, and then they'd fall apart in the afternoon. So then they start sending doses to school. So the school nurse or the principal's office would take the medicine, and the kid would have to go to the principal's office or the nurse's office in the afternoon to get their pill. So there was a little bit of a stigma there. So once Adderall came along, it lasted 7 to 8 hours. You could almost get through the school day. So it started to become more popular because it lasted longer. Later on, they started coming up with longer acting formulations, which we'll look at. So start with amphetamine or methylphenidate. If you don't get the right response or you get some kind of side effect you don't want, try a different stimulant. So if you try one and it doesn't work, try the other one. Third, go to non-stimulant. Obviously, you want to balance the benefits and risk. 66% of children are on methylphenidate, 80-90% of adults are on amphetamines. And that's simply because they tend to be tolerated better or work better in the different groups. Start the dose low, go slow. avoid short-acting preparations as possible, simply because there's a little bit more a risk that they're going to be misused. But short-acting preparations oftentimes are generic, where the other ones are branded. And for a long time, that was a factor, is the cost factor, the availability factor. There's shortages of these drugs across the country, and a lot of people get their prescription and have difficulty filling them. Be aware of diversion, look for symptom improvement, look for functionality improvement, adjust for onset of action and duration. So some people get to school, have classes in the morning, and they need something to get them jump started and get them focusing and concentrating early on. The short acting ones wear off. The longer acting ones take maybe an hour or two to start to work, but then they'll last 10 to 12 hours. So you're trying to get the right balance for the individual patients and what they need for their school or work. Again, I'm not going to go through all these, but if you need a reference, this is giving you the long-acting extended release available meds, short-acting available meds. And again, they're basically, it boils down to Adderall type drugs versus Ritalin type drugs. The non-stimulants, the old ones that were used were clonidine and guanfacine. And then Strattera came along, Intunif came along, Capvay. So there's various long-acting non-stimulants. Bupropion is Wellbutrin, which was an antidepressant. It helped. There was a long Wellbutrin extended release. The newest one is Quellbree or Viloxazine, and its advantage is it's long-acting, but it has a short-acting component, so it kickstart it and then lasts more through the day. You're all probably aware of stimulant side effects. Decreases appetite, may disturb the sleep, may give headaches, abdominal pain, behavior rebound. Again, a lot of those affect kids more than adults. If you're a little 7-year-old and skinny already, then keeping the weight up is a big problem. So infrequent side effects, weight loss, increased heart rate and blood pressure. You want to be cautious in anybody who has a heart condition to make sure it's safe to give them stimulants. Dizziness, visual blurring, agitation, anxiety, exacerbation of tics. Not common at all, but possible side effects. So one of the longer acting stimulants that was an Adderall-like drug was Vyvanse, and I used a lot of Vyvanse because it was very hard to misuse. It's a prodrug, lasted 12 to 14 hours. Very interesting, they would attach the active molecule to a lysine, which would inactivate it if somebody tried to snort it or smoke it or shoot it. But in the GI tract, there's enzymes to take that lysine off and convert it to dextroamphetamine. So it became a good alternative for especially the younger patients where you were concerned about them misusing it. Concerta was the long-acting Ritalin product. Excuse me. Jump the gun there. They used an osmotic pump mechanism, so they had little nodules in the capsule, and some had a thick coating and some had a thin coating. So the thin coated ones released first, and then the thick coated ones released later. The Concerta capsule actually goes through your entire system, and you excrete it out the other end. But again, it was less abusable than immediate release, and it lasted longer and got people through the day in time to do their homework. Newer stimulants. Relexi is a controlled release methylphenidate. Again, it's using an osmotic delivery technology, and it lasts 12 to 13 hours. So again, you want something that gets them through the day, lets them do their homework in the evening, but still go to sleep at night. For adults, lets them get through the day, lets them deal with the things they need to deal with at home in the evening before it wears off. Another way to avoid misuse is transdermal patch stimulants. The advantage of these is they can last longer, but you can remove it sooner if you don't need the effect any longer. So you're putting the patch on, you're getting the medicine, and if you want to stop it, you can take the patch off and stop it. It's very hard to misuse these. The actual amount of the dose is about 25% less because it avoids the first pass through the gut. So there's one called a dextroamphetamine patch called Zelstra and a methylphenidate transdermal patch. So patches is another alternative. Again, many of these things are still branded, expensive, and may or may not be available to you in a clinic situation. So those are the medications, but don't forget to refer to psychotherapy because people can learn organizational skills. They can learn how to do things that will help them be more organized, more focused, and more apt to deal with their life. So therapy can be very important. There are support groups out there, the ADDA, Attention Deficit Disorder Association, or CHAD, which is Children and Adults with Attention Deficit Hyperactivity Disorders. These groups are all over the country. They're online, and they give a lot of social support to the patient and their families. So I've included some references and resources that we don't need to go through. This is simply somebody else doing the same things we've just talked about, looking for symptom overlap, retrospective diagnosis, cultural societal differences. Again, certain cultures can even not recognize it because of cultural differences. Women and girls tend to be missed. Get that comprehensive history, get the longitudinal history, get history from other people, use diagnostic tools, evaluate the functional impairment, rule out conditions, and give them psychoeducation and collaboration. Are there questions?
Thank you. Thank you, Dr. Norris. That was really enjoyable and informative. I'm looking at the chat. I don't see any questions yet. Please post your questions there or Q&A so we can pick Dr. Norris's brain about anything else you've been wondering about in terms of managing ADHD in your clinics. I am wondering in the FQHC world whether you have mental health professionals connected to the clinics who would often manage this, or whether you manage this on your own as primary care physicians. Oh, and there one answer is both from the host clinic. Okay, Dr. Mazzullo wants to ask a question. Let me unmute him. John, I think I unmuted you.
Yes, you did. Hi, Deb. How are you doing?
Hi.
Good.
Hi, doctor. That was great. I'm a retired adult primary care. And one of my biggest problems was inheriting a pediatric patient that had been treated for years and years on Ritalin, and they're starting college at 18 and they come to me. And I've always been worried about not having any information other than they want to refill. And because, Boston's a college town and we get tons of people like that. What would you suggest? I know what I finally wound up doing, but what would you suggest that those of us that are faced that? What's the best approach?
Well, I would still do the screening. At the very least, I would do the screening tests. At the very least, I wouldn't give them the prescription the first time. I would send them home with a test for their mother to fill out. I would try to send for the records of the previous treating physician. And so if someone was treating them somewhere, they should have records And so I would always have them sign a release of information and send off for that information. That said, sometimes all that is not very easy. So what do you do if they say, "Oh, my mother died," or the doctor who was treating me is no longer in practice, or I mean, so, and then it gets down to you making the decision. How comfortable are you with this particular patient, and that they're telling you what is correct rather than what they're trying to do other things with. And unfortunately, sometimes it can be both. So you can have some ADHD patients who also make a little extra money by selling the Adderall on the side. So it's what part of what makes it very challenging. And so sometimes for me, it was developing a relationship with the patient over time before I would feel very comfortable.
Yeah, I agree with you.
Certainly, I would start out giving them, a 1 month supply, not a 3 month supply. Patients that I'd had for a long time, you could do a 90-day supply on scheduled drugs, although we had to write out monthly prescription. We could give them 3 monthly prescriptions with dates saying don't fill before a month from now, don't fill before 2 months from now.
I agree with you.
But I'd only do that with people that I knew fairly well. So I would make the effort at least to get that other information, and I would certainly have them do some screening tests so that I at least had some documentation that I had considered these things and tried these things.
What I wound up doing was giving the 1 month prescription, having them sign the release, and I almost always sent them to the ADHD specialist in psychiatry. I just felt really uncomfortable, doing that. But I always felt that maybe I was abusing the specialist. But I'm a big city doctor, and I was just so afraid of diversion. And the only way I could feel safe was to, give them that 1 month and then send them off and try to get the old records.
The fear about diversion is real, and diversion is real, and yet it's so rewarding to how you can help people sometimes when they really need the medication. So it really does make it a challenge of how you sort that out for yourself, and what's in your patient's best interest. And I think historically, the couple of times that I got caught, or I caught someone, ironically, was somebody that I dealt with for a long time and was much older and should know better. And I caught him through the state drug list, where they were double dipping. They were going somewhere and getting the medication twice, and I was able to catch it on that drug list. But the couple times it happened, it wasn't college kids; it was older people who really knew better. But it happens. But at the same time, you don't want to undertreat people who really are going to benefit from the treatment and the medication.
Okay, thank you. Does that answer your question, John?
Absolutely. I'm glad I'm retired, though.
Thank you. Okay, we have a few more questions. What are thoughts about urine testing in primary care? I have a 20-year-old patient that tested negative for amphetamines ×3, and I'm wondering about the half-life.
Well, it depends on what they're using or abusing. So, I mean, half-lives can be all over the place. There's short-acting and long-acting. So was it fearful that they were using like cocaine and street amphetamines or prescription drugs?
I don't have that information. Maybe the person who asked can clarify that on the Q&A. Maybe what we can do is go on, and if I get clarification, then I'll revisit that one.
Okay, I would just say that in general, I did not use urine drug screens for patients with ADHD. If they were a known substance abuser and I was worried about them relapsing, then I might use urine drug screens to see if they're using something else, but not in general for ADHD.
Okay, thank you. What should we tell patients asking if this is a lifelong medication?
Well, I like the psychologist's statement. It's like putting on reading glasses for the first time. Um, I have to wear reading glasses, but I don't wear them all the time. So you really you put them on when you need to focus and concentrate, and if you don't, then so I had patients that would use them Monday through Friday, but not on the weekends. But it, but there's no curative treatment. So yes, as long as you want to be able to focus and concentrate, you would need to use the treatment.
Okay. I have a colleague who would overuse caffeine intake as a means of self-medication. Have you seen this to manage adult ADHD? Also, is hoarding behavior part of this spectrum?
To me, hoarding behavior would be a comorbidity that would
Yes.
fit more into the anxiety spectrum syndrome. So it's a variation of obsessive compulsive disorder, which is part of the anxiety spectrum. So no, I don't think it would be particularly relevant to ADHD, but it could be a comorbidity with ADHD.
And then caffeine intake as a means of self-medication.
Caffeine is a stimulant, and there are some caffeine drinks out there now that would make us old coffee drinkers look like amateurs. I mean, so the very high caffeine content drinks that the young people drink. And so, yeah, I'm sure that they get some stimulant effects from that.
Okay. Any studies on screen time and correlation with diagnosis rates?
Uh, Probably, but I'm not aware of them. But if you think about it, I think that may be another reason why we're seeing so much more talk about ADHD today is with screen times, people get distracted with their phones. Watch television and watch one of these CNN type stations, and they're giving you one story, and there's 2 or 3 banners going underneath, giving you different stories and numbers and stock market numbers. And I mean, that's all distracting. So we're kind of teaching our kids to be distracted from the very beginning now. So I'm sure that that's part of why it's becoming more recognizable to everyone. Next time you go in a restaurant, look around and see how many people are talking to each other versus everyone's looking at their phone. So distractibility is out there. And if you're distracted on your phone, you're procrastinating, you're forgetting to do things, things aren't getting done. I think we have a society that's leading us more and more towards ADHD.
Okay, thank you. Any resources for patients waiting for months to get into psychotherapy?
More and more being talked about AI therapists and therapy online. There is telehealth now, and at least at the moment, telehealth is still approved even for ADHD and stimulants. So people can probably get into telehealth pretty quickly. But at least in my area, yes, if you send someone to a good therapist, they're going to wait to get in because there aren't enough people to go around. So it's challenging whether or not the stuff online will turn out to be useful or not. Some studies say yes, some studies say no. I think it's still an area that's being explored, but someday you'll probably be talking to an AI who will be giving your therapy.
Okay. Those are all of the questions at present. Any last comments before we close? I know that Dr. Norris and our other child and adult psychiatrists are also very available for consultations. So that may be an additional resource for you. And I'm not seeing any other questions. So again, thank you so much. I think I'll stop recording.